Good morning, everyone. And today, Dr. Rahul will be presenting the case, and it will be moderated by Professor Jeswanth, Professor Vaibhav, Varshney, and Professor Parthasarathy. And Vaibhav and Parthasarathy will be joining us shortly. In the meantime, Dr. Jeswanth can take over. It's all yours, Dr. Jeswanth. You can take over now.
Yes, Rahul, please start the presentation.
Thank you, sir. So, case capsule started with 61-year female resident of Tripura, homemaker by occupation. She presented with the chief complaints of difficulty in swallowing solids for the past 2 months. She was apparently all right 2 months back when she noticed difficulty in swallowing solids with a sense of bolus of food stuck at lower chest, which was gradually increased in severity and is not associated with pain during swallowing. She is able to swallow liquids without any difficulty. She also complains of epigastric discomfort and retrosternal burning sensation since 2 months. She also gave history of halitosis. I would like to know the duration or if there is any neck swelling or gurgling sound is there or not from the past. As there is history of loss of weight associated with loss of weight, 5 kg in 2 months, significant. No history of blood in vomitus or clay-colored stool, no history of regurgitation, no history of abdominal chest pain, no history of altered bowel habits, no history of any corrosive injury or vomiting or abdominal distension, no history of any other chronic drug intake, no history of cough, dyspnea, hemoptysis, fever, no history of icterus or backache, no history of mass per abdomen or palpable swelling elsewhere. I'd also like to know any treatment history in the form of endoscopy or ultrasound or any other form of investigation was done or not. Past history, known diabetes mellitus is on oral hypoglycemic agents, no history of any previous surgeries, no history of similar complaints in the past. So sleep and appetite of the patient is normal. She's having addiction of bitter nut chewing since 25 years, consumes mixed diet. Bowel bladder habits are normal and regular. No significant family history. Sir, should I summarize my case?
Please.
So, 61-year-old lady with diabetes mellitus presented with complaints of painless progressive dysphagia to solids, progressing to liquids for 2 months, with epigastric discomfort, retrosternal burning sensation, and halitosis for the last 2 months, associated with loss of appetite and loss of weight, with no history suggestive of dissemination. So, my differential diagnosis, I would like to put malignancy of carcinoma esophagus and carcinoma or a carcinoma esophageal gastric junctions.
Just use this room.
Okay. So, any other diagnosis?
Sir, since I can kept motility disorders, but because the age of the patient, 61-year-old, and the short history span, 2 months, and associating with loss of appetite also and loss of weight, I would like to keep malignancy, and I don't want to keep motility disorder or achalasia cardia.
Okay, in the history you wanted to know about gurgling sound and neck swelling.
Yes, sir.
Mind?
Sir, I want to rule out if there is any associated diverticulum is there or not in the patient, because patient is giving history of halitosis. If it is from the last 2 years or so I would like to know if there is any associated disease or not.
Sir, what diverticulum?
Yes, she's diabetic. Yes.
What diverticulum?
Sorry, sir.
What diverticulum?
Diverticulum, sir. Any sir, Zenker's diverticulum is there or not? Yes.
What's the age group for that? For Zenker's diverticulum?
Sir, around 70 years, 70, 80, more than 70 years. Yes.
Okay. What are the cause of halitosis?
So halitosis, any stagnancy of the food will cause halitosis, sir. If the food is there for the long time, then it can cause halitosis or bad smell.
So based on the only weight loss and salt reduction, you are making the diagnosis of carcinoma esophagus?
No, sir. It's a short history. Only 2 months. In 2 months, there is a loss of weight and loss of appetite, and there is a painless progressive dysphagia, sir, which is more suggestive of malignancy.
What is the nature of dysphagia in achalasia cardia?
So dysphagia in achalasia cardia can usually start from liquids progressing to solids, but it can also start from solids also. But it usually starts, so it's saying that if it is usually starting from liquids to solids, then it is more specific for achalasia or motility disorders.
Okay. Partha, you are on?
Sir, good morning, sir.
Partha? Yes.
Good morning, sir.
Morning.
Morning.
Yeah. Partha, you would like to add something?
What can you absolutely rule out achalasia in a patient who has got this painless progressive dysphagia at this age from the history alone? Would you want to completely remove it from your differential diagnosis?
Sir, it can be present, but considering the very short history, sir, I don't want to keep it. But yeah, sir, with a rare possibility, it can be there, sir. But 2 months history is not very suggestive of motility disorders.
Halitosis more common in achalasia or in carcinoma esophagus?
So more common in achalasia cardia.
Reason?
So because chronic stagnancy of food is there in achalasia cardia. In malignancies, there is short history and is associated with regurgitation. So stagnancy is not so common.
What about the capacity of the esophagus?
Sorry, sir?
What about the capacity of the esophagus in both these conditions?
Sir, chronic dilatation of esophagus is common in achalasia cardia, sir. So capacity is there more in achalasia cardia.
Suppose if this patient had painful dysphagia, what would you consider? If she has,
Sir,
if she says there's pain also while swallowing.
So then I would have considered motility disorder or any inflammatory disorder, sir. Probably
You would consider that motility in 2 months history, short history?
Sir, it can be present, sir, if it is sudden onset and it says like 35-year-old lady presented with 2 months history also and chest pain.
This patient, suppose if she had pain also, he says there is pain while swallowing, everything else is same.
So then I would have considered any, sir.
Which motility disorder you will consider in that situation? Sorry.
Sorry, sir.
Which motility disorder would you consider in that situation? You said motility,
The
no?
nutcracker, yes, sir. Any nutcracker esophagus or
that won't fit into all the other things, no? Except for the pain, it will not fit into any of the other history details.
Yes, sir.
Would you still consider carcinoma esophagus in that patient?
Yes, sir. I would still consider because, sir, first I will consider carcinoma esophagus only because that can cause pain in the radiating to back. That can cause pain with the if the throughout involvement is there, and nerve involvement is there, then yes, sir, it can cause pain. And suggested of locally advanced disease, sir.
Okay.
Hello, sir.
Yes.
Rahul, what is the relevance of this epigastric discomfort and retrosternal burning sensation in this particular case?
Sir, I am considering that as a symptom of GERD, and it is more likely that's why I've kept, sir, carcinoma esophagogastric junction as my DD, because
why not as a first DD? If you were thinking of GERD leading to like Barrett's, so why not see a GE junction as a first differential diagnosis in this particular case?
So, because the carcinoma esophagus can also be there with GERD, and it's not specifically if it is there, then carcinoma esophagogastric junction is only the diagnosis.
Can happen, but you need to see in which case it is predominant.
Yes.
And then accordingly, you have to keep the differential diagnosis. I'm sorry for I'm joining late. Was there at what level there was a holdup of food in this particular case?
Sir, lower thorax, sir.
Lower thorax. Okay.
Yes.
So what does this mean?
So that means usually it means that the site of obstruction is below what the patient felt.
Correct. So again, it pointing towards G junction again, isn't it?
Yes, The distal esophagus and G junction. Yes, sir.
Okay. And you asked for the history, family history. What is the relevance of family history in this cases, in this case?
So family history, if there is a family history, then it is more chances of. In this case, I don't think, but in early, in young age group or 40, 30 years of age group, sir, it is more specific that the patient is having this kind of symptoms, then it's more likely to be esophagus.
What familial disorder is linked with C. esophagus?
So Plummer-Vinson syndrome and
If she is 40-year-old lady, then what will be in your mind?
so Plummer-Vinson tylosis is also there, sir. And yes, sir, I think I'm not able to grasp.
So, like when you are asking for family history, you should know that why I am asking this history and what is the relevance, especially in a young age. Okay, I think, sir, can we proceed further?
Yes.
So on general physical examination, patient is she is conscious, cooperative, and oriented with a BMI of 23. Weight is 56 kg. Well built and nourished. ECOG 1. Pulse rate is 73 per minute. BP is 140 by 90 mmHg. Respiratory rate is 14 per minute. Afebrile. There is no pallor, icterus, or cyanosis or clubbing edema, lymphadenopathy. I would like to specifically see for the supraclavicular lymph node, left supraclavicular lymph node, and there is no edema. No signs of any malnutrition or dehydration. So, for abdominal examination, abdomen inspection, abdomen is flat and umbilicus center in position inverted, all quadrants moving equally with respiration, no scars or engorged vein or skin nodules or visual peristalsis, no fullness or visible lump, hernia offices intact, no renal angle fullness, external genitalia normal, palpation, soft non-tender hernia sites, no palpable impulse. Her liver, spleen are not palpable, no palpable lump. Liver dullness is 13 centimeter in the fifth intercostal space, midclavicular line. Flying certain panic. Normal bowel sounds heard, no bruit or venous hum. Distal rectal examination, perianal skin normal, normal sphincter, gloves stained with normal yellow stool. So respiratory system examination, there is no vesicular breath sounds heard. Bilateral air entry equal. There is no added sound and no crepitations. Other system examinations are normal.
Is there anything missed in this examination?
Sir, with the negative history, I have come to know that there is no ascites in the patient, and on respiratory examination there is no any sign suggestive of pleural effusion or because there is bilateral air entry equal. And sir, there is no any lump abdomen, and BMI is good and patient is in well condition with the ECOG of status 1. Yes, sir.
Anything else is missing in this particular case?
Sir, oral cavity, I would like to examine. Patient is having beetle history of beetle nuts, and so I would like to examine the oral.
Anything more specific to the differential diagnosis you've got? See, how common lump in a patient whom you suspect to have C. esophagus?
So there can be
something more relevant expecting.
Sorry, sir, I didn't get you, sir.
Some other more relevant area has to be examined. Supraclavicular node is important.
Sir, yes, I have mentioned, sir, with general
lymphadenopathy. When you say generalized lymphadenopathy, it comes under general examination. So there you are looking. Did you mention the examination?
Yes, sir. Yes, sorry, sir. I have mentioned for specifically, I would look for left supraclavicular lymph node.
Okay.
Yes, sir.
And in oral cavity also, what else you will look for? Because this patient has a history of halitosis, apart from patient has a history of beetle nut. Any other thing would you like to see?
Sir, any patch, leukonychia or any erythroplakia. So I would like to see for any patch or elevated lesion, any sign of malignancy in the oral cavity that can be there associated with distal malignancy also.
Okay. Anything else?
Sir, any bad smell, the halitosis is there, but any.
Like starting from any mouth opening is present or not?
Yes, sir. Decreased mouth opening. Yes.
Scarring present, any loose teeth present or not,
Yes, sir.
any denture present or not, that you should mention, because in this particular case, oral cavity examination is very important, because this is also important from your perioperative care.
Anesthetic point of view. Yes, sir.
That is important. You should mention this in your general physical examination.
Yes, sir.
What is ECOG otherwise?
Sir, one.
What is the meaning of ECOG?
So Easter Corporation Oncology Group grading, it is basically to assess the health of the basically how much patient can do the work, how much work patient can do. If it is very well and he can do every activity of himself, then it's grade 1 with physical activity also. And if it is with limited physical activity, it's grade 2. But if it is only self care is there without any limited activity, then it is grade 3. With limited self care is 4, and if it is bedridden, then 5.
Okay.
So should I summarize, sir, please?
Please summarize it.
So 61-year-old lady with comorbidity of diabetes mellitus presented with complaint of painless progressive dysphagia to solids and to liquids for 2 months with epigastric discomfort and retrosternal burning sensation and halitosis for the last 2 months, associated with loss of appetite and loss of weight, 5 kg in the last 2 months, and no history or suggestive of dissemination. The general physical examination is unremarkable. Differential diagnosis, I have kept both the differential diagnoses after carcinoma esophagus and carcinoma esophageal.
Have you mentioned about treatment history in this case?
Yes, sir. I have mentioned in the history part, sir. I would
Okay.
like to know.
So how will you like to proceed from here? What do you want to do now?
Sir, I would like to know the general condition of the patient with the investigations, complete blood picture, renal function test, and albumin and liver function test. Along with, I would like to diagnose my disease with the upper GI endoscopy and also ultrasound whole abdomen and chest X-ray.
So here are the investigations for you.
Yes, sir. Let's see. Sir, hemoglobin is 13. Hemoglobin is 13.3 with TLC count normal 7,000. Platelet count is normal. So blood urea and serum creatinine is normal 139. Sodium and potassium is in lower range 3.4. Sir, LFT is normal with serum albumin of 4.4 and INR 1.15. Sir, upper GI endoscopy is suggestive of ulceroproliferative growth noted in mid-esophagus at 30 to 35 centimeter from incisors. And the stomach is normal, duodenum is normal.
So what do you want to do now?
So I would like to know the ultrasound and chest X-ray if it is done, if it is normal.
Ultrasound abdomen is this. Any interpretation, Rahul?
Hello, sir. Hello, sir.
Have you read any interpretation of this?
Sorry, sir. There is a network problem. Sorry, sir. So I just got disconnected with the network. Sir.
Proceed. Have a look at the ultrasound report and then anything.
The liver is normal. Yes, sir. Sir. 7:30. Sir, I would like to stage the disease, sir, with PET CT.
No.
Confirm the diagnosis. You have never asked for the
No, so
biopsy.
sir, biopsy. Sir, I would like to see the biopsy. Yes, sir.
Endoscopy was done. The patient came
Yes,
with the.
sir.
You never asked for the biopsy report. You asked for the
Sorry.
ultrasound.
No, sorry, sir. Sir, I would like to see the biopsy.
To do an endoscopy again because you
No,
missed.
sir. I would like to see the biopsy, sir. Sir, biopsy is suggestive of invasive non-keratinizing squamous cell carcinoma.
So what is the implication like at what level the growth was? What is the biopsy report? What picture is coming into your mind now? What is the level of the growth?
Sir, it is from, as per upper GI endoscopy, it is from 30 to 35 centimeters. So it's below carina. So I would like to stage the disease now.
At what level? Like what is how we classify? How we
Sir, it's a lower thoracic esophagus.
what is the upper and what is the lower mid thoracic esophagus? What is the
Sir, it's starting from with the 20 to 25 centimeters, upper thoracic 25 to 30 centimeters, mid thoracic, then 30 to 40 centimeters, lower thoracic esophagus.
what are the anatomical landmarks for this?
Sir, sir, carina is a landmark for mid thoracic esophagus above to 5 centimeters mid esophagus, sir, and from inlet to pulmonary artery, it's upper esophagus.
Think properly and then answer the question that what are the anatomical landmarks for division of the esophagus? But that will help you when you ask for the next information that you should know where it is.
So, carina is a landmark for lower thoracic.
Carina, okay, that is at what
Yes.
level?
I'm not able to guess.
Upper thoracic from inlet to carina, it is upper thoracic, that is 25 centimeters. Inferior pulmonary vein, that is a 30 centimeters.
Yes.
The lower thoracic esophagus.
Yes.
My impression on upper GI endoscopy, thus this is a tumor of the lower thoracic esophagus with the invasive non-keratinizing squamous cell carcinoma. So this is, you have to interpret it. Okay. So when you have taken a biopsy, nowadays, any other thing you ask for apart from the histopathology?
Sir, in biopsy from
In
pathology?
done, biopsy is done. Apart from this, any additional thing you would like to see in the tissue, you ask for, that is important nowadays.
Sir, any signatory in cell or any?
That is the part of histopathology.
Yes, sir. Sir.
Any molecular, any bio?
Immunohistochemistry. Since squamous cell carcinoma, it is not poorly differentiated, then.
Have you ever heard of doing the things of HER2, MMR, MSI testing, PDL1?
MSI, yes, sir. MSI and MMR can be done. Yes, MSI can be done.
This is a future implication. So if it is nowadays, you have a tissue, so you need to do all these testing if it's available in your center and patient condition is good. So doing HER2, it has shown to have a significant, like in squamous cell carcinoma also, it has shown to, it is positive in what percentage it is positive in adeno and what percentage it is positive in squamous cell carcinoma.
So I don't know the exact number.
This is important, like in some 20-30% is positive in adenocarcinoma and 13% it is positive in squamous cell carcinoma. And if it is positive, it has a poor prognosis. So this thing, similarly, MSI, MMR and PDL1 is also important. So people extend these investigations nowadays before you give any other treatment modality, because this is a de novo tissue. So this also is important. Sir, please proceed, sir. Dr. Jeswanth, Dr. Partha.
Rahul, do you want to ask for anything more during the endoscopy? Any more information?
Sir, I would like to know the extent that they have mentioned that it is from the 30 to 35 centimeters. So I'm considering that it is the only extent of the lesion. And sir,
The
you have-
endoscopic landmarks are different from anatomical landmarks you use for dividing the esophagus. No? You cannot see the inferior when you cannot see the esophagus.
yes.
So what else would you ask the endoscope? The endoscopist can give you some other landmarks. What landmarks you want to know?
So they can say that from the G junction, how much above, because when they withdraw the scope, then they can tell us that from the G junction that lower extent of the lesion is this and the upper extent from the G junction is this. So that can be said.
Anything you want to know when they start entering the esophagus?
Sir,
Vocal cord mobility.
vocal cord mobility. So they see the vocal cord mobility.
Is it relevant?
Sir, in this case, vocal cord mobility, if it is lower thoracic esophagus.
Can you still have vocal cord paralysis in this case?
Sir, recurrent laryngeal nerve can be involved, but sir, it's 30 to 35 centimeters. Sir, thanks.
Apart from primary, can they be involved by lymph nodes?
Yes, sir, it can be involved by lymph nodes. Sir. Yes, sir.
It doesn't take much effort. Now, when they enter, they can just see the vocal cord.
Yes, sir. Yeah, they usually
Can
see.
have symptomatic vocal cord paralysis pre-existing in this patient, unconnected to the cancer.
Yes, sir, it can be diabetic mellitus. Yes.
The post-op period.
Yes. Sorry, sir.
That is important in the post-op period.
Yes,
if they
sir.
already have an existing vocal cord paralysis,
Yes, sir.
after the surgery, if you find vocal cord paralysis, you will know that it was existing pre-operatively itself.
Yes.
Anything to see in the stomach?
Sir, stomach is in this patient it is normal.
Why would you want to see the stomach at all?
Sir, because we have to make a conduit, so stomach should be normal. My first choice would be stomach. Sir.
Abnormal meaning what are you worried about?
Sir, any fluid? Sorry, sir.
You said stomach has to be normal because you need to use the stomach as a conduit.
Yes.
What can be abnormal in the stomach which will change your decision?
Sir, severe gastritis, any other lesion in the stomach or extent of the lesion. If it is G junction, then the extent of the lesion in the lesser curvature is more, then I would not be able to use stomach.
Can I have gastric polyps?
So we can have gastric polyps with the no low grade dysplasia or with less than low grade dysplasia. It's not contraindication.
Any other thing, because this patient has a history of halitosis. So anything you want to like specifically see in the...
So diverticulum, I would like to see in the upper esophagus if it is there or not. Yes.
Okay, that is the thing. On the mucosa?
Sorry, sir?
On any mucosal lesion in the esophagus? Any candida patch? Any leukoplakia?
Yes.
That's also important.
That can cause, but...
So that you need to see in that upper GI. Additional important thing you should keep in your mind when you are asking for an endoscopy report. Sir, please proceed.
Yeah. So having done endoscopy, on to the next what investigation?
So biopsy is there. So I would like to stage the disease with the cross-sectional imaging of PET-CT.
Why straight a PET-CT?
So because it is a squamous cell carcinoma, and PET-CT is a good investigation to rule out, to stage the disease also nowadays for carcinoma esophagus and for metastasis also. So in one go, we can completely stage the disease.
What is the problem with directly doing a PET-CT? Is there any downside to doing a PET-CT versus a HRCT chest?
Sir, HRCT is because HRCT is good investigation for better investigation to look for small less than 1 centimeter nodules in the pulmonary nodules.
No,
Then
as regards
CCT. So then CCT in the PET CT. Yes, sir. But PET avidity have a good, if it is squamous cell carcinoma, then and it is not poorly differentiated, then PET avidity is a good marker to diagnose the metastasis in the lung or any elsewhere.
PET is a functional CT.
Yes, sir.
When compared to the spatial resolution, a regular CT usually scores over a PET CT because the anatomical resolution of a PET CT is usually inferior to a regular CT. You must have seen this in many of the PET CTs you have seen in the OPD. So that is
Yes,
one
sir.
small to PET.
But if we are having a good investigation model and the CCT is equally good, then only it is better. Yes.
So still you have not Dr. Partha's questions. What is the drawback of PET CT? PET, if you like, you said that you are going to stage the disease.
Yes,
So
sir.
it will give you an answer for metastasis. So the other part of the staging is your T and your N. So will
Yes, sir.
PET will give you that answer?
Yes, sir. It's equally good if done in a good setting. If the CCT and the CT part of the PET CT, it's done as per the protocol, then yes, sir. It is equally good.
Part is important because
Yes.
PET will, because of the metabolic uptake, it will not give you exactly clinical T and your clinical N staging. For that, you need to look at your CT scan. PET is primarily for the ruling out metastasis. Dr. Partha, Dr. Jeswanth can correct.
Yeah, I agree.
Suppose if by CT scan, you might have pulmonary mets or liver mets, would you like to do PET CT?
Yes, sir. Then also we have to do a PET CT because then if we are giving for palliative chemotherapy also, then we have to compare with the previous investigation. With the same investigation we will do with in the post chemo period. So PET CT is important.
What is the role of endoscopic ultrasound in carcinoma esophagus?
Sir, endoscopic ultrasound is for early lesions to differentiate between T1, T2 lesions. So that if an EMR or ESG, if you want to consider for T1A, T1B lesions, then it can be done. Or for the picking off of lymph nodes also. If it is adjacent lymph node is there in the vicinity of the tumor, then yes. And FNAC, good FNAC from the lymph nodes.
In US, how would you suspect a node is malignant?
Sir, if it is more than 1 centimeter, it's globular, it's then yes, sir. It's
No, clear criteria.
so more than 1 centimeter in size, circular in shape, and sir.
What is the criteria called?
That I
Proceed.
Can we have a CT scan, PET CT scan?
Sir, I will not. Sir, I won't be able to control it because of iPad. So please, you can do for me.
Which phase do you want to see first? Is the
So
CCT
non-contrast phase. So can you scroll down, please?
So what do you want to see in non-contrast image?
So I
What-
want to see if there is any pleural effusion is there or not, if there any site is there or not, or any calcification in the aorta, SMA or celiac plexus is there or not.
So is there anything?
No, sir, I don't think, but there is a lesion in the liver, but I will look at it through the arterial phase.
Okay.
Yes, sir. Arterial phase. Lung seems to be, sir, normal.
For lung, you need to see that lung window.
Thoracic lung window, yes.
You should not comment here.
Okay, sir.
What are you trying to see in the lungs?
Sir, any nodule or pleural effusion is there?
Anything else?
Sir, any no, sir, I don't think.
Had dysphagia, halitosis. There can be microaspirations.
Aspiration.
Yes, aspiration pneumonitis can be there. So that will,
Lung abscess and so on. Okay.
yes. Seems to be, sir, normal.
Okay.
There is a contrast lens cross section imaging of the right CT. Esophagus is dilated. Really dilated.
How can you say it is dilated? What is the normal diameter of esophagus?
Sir, it's though it is a normal anatomical diameter is 2 centimeter, but on scan, if it is seeing more than a point, then it seems to be it's dilated only. Sir. The scan is usually collapsed. If it is the so there is a thickening in the subcranial region, starting from subcranial region. Esophagus.
Where is the carina? Can you like point out and from where it is starting?
Yes, sir. Yes, sir. I can point out. Sir, just go up, sir. Slightly up. Up. Sir, stop.
Okay.
So,
So
this is the carina.
that's
So
just
just below this, the thickening is starting.
Do you think?
Yes, sir. This.
Okay.
Yes, sir. So with the left bronchus, the fat planes are very. It doesn't seems to be good fat planes with the bronchus, but maybe it may be because there is no irregularity in the bronchus, so it may be because of thin patient. Yes.
So what? Because of thin patient.
So there is no general if there is no irregularity and the patient is thin and there is no fat, then it can be this loss of fat plane can be there. If there is no irregularity in the.
This patient has BMI of 23.
Yes, sir.
So, okay, proceed further. Where is the what is this structure coming?
Which one, sir?
This
White structure. Aorta.
no, anteriorly. This one.
This is hmm, I guess arterial fascia.
Because you can see that the bulk of the disease is here.
Yes, sir. It can be pulmonary.
Can you scroll up, slightly scroll up, please? So when we were discussing about that anatomical landmark, you mentioned about what structure was there that gives you the lower 1/3 at what level it starts.
Pulmonary vein, sir.
So you can see that this.
This is the.
So
Yes.
you can see the bulk of the. Can you just stop there? Can you see the esophagus, the bulk of the disease?
Yes, sir. It's very thickening is there.
Okay, so like you have like when you are describing, so you have to describe about the T staging of the tumor. So
Yes, sir.
anteriorly and posteriorly. So what is anteriorly? What is posterior? How
So
you
posteriorly is aorta, anteriorly is pulmonary vein. So both the and the trachea. So fat planes are maintained with both the.
apart from fat planes, is there anything else which you would like to see when you're talking about aorta?
So picus angle is also there, but if it is not
What is
involved
picus?
in there. So picus angle is when there is loss of fat planes with the aorta, at which degree it is, then it is suggests that if it is less than 40 degree, then it is unlikely to be involved. If it is 40 to 90 degree, then 40 to 50% involved. If it is more than 90 degree to 120 degree, then 80% chances are of involvement. And if it is more than 120 degree, then almost 100% chances of involvement. So it is basically to suggest that if it is involved or not.
It is basically if it is more than 90, there are chances that there are,
Yes, sir.
and it is 40.
80%.
It is 40. It is graded as 45 to 90,
Yes, sir.
and it is basically picus angle is the angle of contact of the tumor aorta, how much it is. So how clinical T staging in this patient, and then the N staging. Can you see any lymph nodes?
Till now, I have not seen any lymph node.
Can you comment upon clinical T and clinical N in this CT scan?
Sir, T is T3.
How you are saying it is T3?
So T2 or T3 basically, because it's there is very fat stranding is also there, so it's more likely it's T3, sir.
Rahul, can you show the esophagus vein? You can ask them to scroll and
Yes, sir.
where you can see it well.
So if it is portal venous phase, then it is like.
That phase is for the abdomen only.
The esophagus vein drains the portal or the systemic circulation?
So systemic circulation.
So where it will be? At what level it comes?
Sir, just below carina.
At the carina.
Why I'm asking is the esophagus vein involved by the tumor in this case? Scroll down a bit.
Scroll down, sir. Scroll down. Sir, I think that was the esophagus vein that crossing.
You can scroll down, you can see it much better. Yeah. Scroll up, please. Yeah, wait. That is the esophagus vein.
Yes.
Can you? So if you see the vein disappears after some time into the bulk of the tumor.
Yes. Yeah.
So what will be the T stage of this tumor?
Sir, T4A, you can, if esophagus is involved. I'm not very sure if it is involved, but yes, sir, if it is involved, then T4A.
It's definitely not T2.
Not T2, sir. If it is T3 or T4. Because there is fat stranding is there, sir, in the vicinity of that. T3 is there.
Any intrathoracic lymph nodes?
Sir, I'm not able to appreciate thoracic lymph nodes. You can scroll up.
Okay, finish your interpretation.
Sir, I would like to see the liver. Scroll down. So, thickening ends at this level just. Yes.
Now can you see the esophagus vein very nicely?
Yes, sir. Scroll down, sir. So there is a lesion, hypoechoic, well-defined lesion in the liver in segment 7 or 8 junction. So I'd like to.
Rahul, you should use the word like you said hypoechoic. It's a CT scan.
Hypoenhanced, sorry. Hypoenhanced lesion in the 7 8 junction. So it's well-defined lesion. Seems to be symphysis, but still I have to characterize it with MR.
There is another lesion in segment 2. Can you scroll it? Just wait. Yes.
Yes, there's a small lesion in segment 2 also. It's around 0.5 centimeter.
Anything else you will like to see in the abdomen phase, Rahul?
Yes, sir. Abdomen, I'd like to see any ascites is there or not, sir. And any lymph node is there or not. Though it's very.
Lymph node. At what level?
Sir, the level of celiac lymph node is there, left gastric lymph node is there or not. And see, ascites is not there, sir. No interbowel fluid and no hazing of mesentery. No any nodule in the mesentery till now. Yeah. Just scroll down, sir, please. Slightly scroll down. Seems to be thickening of this this palaro junction, palaroduodenal junction is there. It seems to be normal, no fat stranding. So no, is no lymph node is obvious lymph node is not there in the abdomen. No ascites. There are two lesions in the liver which have to be characterized further.
What do you want to do next from here?
Sir, MR upper abdomen to characterize the lesions, sir.
But we can do an ultrasound also further to characterize them. Do you think there looks like a
No, sir, it doesn't look like to be malignant. It
No,
seems to
Rahul,
be simple
what is the
cyst.
studying now? It's a PET scan, na?
PET scan. Sir, avidity, yes, sir. I would
Why
like to
wouldn't
see
you
that.
want to do that? Go ahead and see the PET avidity.
Yes, sir. Avidity, I would like to see, sir. Sorry, sir.
The cystic liver secondaries are common in squamous cell carcinoma. So keep it in mind, actually.
It was a non-pet evident lesion, sir.
this is compatible? Okay, this your
So
query.
whenever you see
What
cystic
next?
lesions, keep it in mind. No notes are involved.
Yes, sir, no notes are there, sir. But no obvious roots.
Okay, let's see the PET report.
Please share the PET report.
Yes, sir.
So, upper intensively heterogeneously enhancing asymmetrical circumferential wall thickening with a SUV of 18.2 involving middle third of the esophagus, length 3.8 centimeter, extending from upper border of D5 till upper border of D7 vertebra, causing linear narrowing of extreme direction of the esophagus. Sir, yes, sir. Sir, there is one node is there in the unknown FDG with enlarged necrotic gastrohepatic lymph node is there. Around 1.4 into 1.4 centimeter cystic density, and a non-FDG avid thin walled non-enhancing cystic density in segment 7 of liver benign etiology simple cyst.
So what do you want to do now?
Sir, I want to do the FNAC of this EOS guided FNAC of the lymph node of gastrohepatic region. Yes.
Why?
Why?
No, sir, enlarged lymph node with more than 1 centimeter, 1.5 into 1 centimeter with 6.2 avidity. So,
What are the differences you're considering in this? There is a tumor in the esophagus. There is a FDG avid node
yes, sir.
in the draining area. Why would you want to FNAC? And the radiological T stage is at least T3 or T4.
T3, sir, yes.
If the
Sir,
FNAC comes no malignancy, will your treatment protocol change?
no, sir. So, but it's a gastrohepatic lymph node, sir. So it's in the abdomen.
See, a PET will always give you a report like that, gastrohepatic. It cannot give you a spatial report. It cannot tell you in relation to an artery. Get it?
But
It will
sir,
only give
CT is also there, sir. CECT is also there.
So if you say gastrohepatic, which artery is most likely involved? Which group of node is that?
Sir, left gastric more likely.
It can be left gastric. It can
Can
be
be common hepatic also. It can be
unlikely. It can be left
Hmm.
gastric.
yes. So sir, if it is left gastric, then it is lesion is in the sir mid thorax, and if the lymph node is in the abdomen, so I'd like to.
So I don't think it is required.
Sir, if it comes out to be positive, then so it's a non-draining non-regional lymph node with respect to the lesion, sir. That's why I want to.
Dr. Parthasarathy Jeswanth can comment whether it is.
What are the lymph nodes you would resect if you do a curative surgery in the carcinoma esophagus in the abdomen?
Sir, up till celiac lymph node, left gastric common hepatic celiac.
Will it come in your routine lymphadenectomy zone, this lymph node?
Yes, sir, it will come.
So would you still call it non lymph node?
It comes a regional lymph node, not metastatic lymph node.
This is a
Not
regional
criteria. Yeah.
Okay. Okay.
is not required. So what will you do now?
Sir, I would like to discuss we have stage, it seems to be sir clinical staging CT3 and CN0 and CM0. So I'd like to discuss the case in the
N0, it is N1, Rahul.
N1, sorry sir, N1, N1 and CM0. So I'd like to discuss the case with multidisciplinary team. Then I'd point as my advice, because it is N1 disease, so she will need chemoradiotherapy.
What chemoradiotherapy will you do?
As per cross protocol, sir,
So-
carboplatin.
No, chemoradiotherapy can be definitive, neoadjuvant, preoperative. What would you give?
So preoperative, I will suggest preoperative, then preoperative followed by.
What is the role of bronchoscopy? You are suspecting some infiltration with the bronchus.
Yes, sir.
Suppose either it's infiltration of the trachea or bronchus, will you do radiotherapy, obvious infiltration? Will you do bronchoscopy?
Yes, sir. I will do bronchoscopy, sir. If it is fat planes are not maintained, then
Since you are suspecting, it's better to do bronchoscopy also.
yes.
How do you know on bronchoscopy is involved, bronchus is involved or not?
Sir, on bronchoscopy, if there is any elevated lesion and mucosa is irregular at that point of
Erythema.
contact.
You may not see
Erythema.
obvious.
Yes, sir.
No. Okay.
So
So
what?
Father ask, definitely, Father, please continue.
Sir,
Sorry,
what you want to give?
Sir, chemo as per cross protocol, I will suggest in the MDT team from our side, so, as per cross protocol, with the intent of resection and definitive treatment, preoperative chemoradiotherapy, carboplatin plus paclitaxel plus 41.4 grays of radiotherapy in 5 cycles, 5 days a week, in 5 weeks.
And after that, what will you do?
So in the interim period for after 2 weeks, I will assess the response of the.
After how many?
Sir, after 2 weeks of starting the radiotherapy, I will assess the response with PET CT and clinically, and if it is responding, then we'll continue with the chemoradiotherapy, and after 6 weeks. After completion of the 6 weeks, I will again do the PET CT and then plan for resection, sir, if it is resectable.
We have post-treatment. What treatment was given?
So
Here?
chemoradiotherapy, sir.
Here.
Sorry?
See the slide.
Yeah, chemoradiotherapy was only given, sir. Says carboplatin and paclitaxel.
Okay. Can you have the post-treatment picture? Report? We'll just have the report.
Yes.
Complete metabolic resolution with significant decrease in thickness and extent of the prior noted intensity FDIG primary lesion. Maximum thickness measuring 6 mm versus 12 mm previously. Low grade FDG with tiny right axillary lymph nodes noted in the previous reactive. Rest is same. Complete metabolic resolution of the lymph node also.
So what will you do now?
Sir, I will
CT on CT now. What do you want to do next?
Sir, after prehabilitation, I would like to advise for the resection.
What surgery?
Sir, transthoracic esophagectomy, our Lewis.
Ivor Lewis.
So because there is it's a infracarinal disease.
So
It says commercial carcinoma. How much clearance would you give?
Yes, a total esophagectomy will be required in this case. 10 centimeter of margin.
As the patient, I said that is a complete on PET CT. Why you want to operate on me?
Because sir, PET CT is the complete resolution radiologically does not correlate with the pathological complete response, and there is a chance of 70% chance of recurrence in the 2 years of the post-operative chemoradiotherapy, post-chemoradiotherapy. So it's better to resect and.
Can you confirm with further investigations whether it is a complete response or not?
So we can do upper GI endoscopy again and then do biopsy.
Can we have upper GI endoscopy of this case? There is a mild scarring, no thickening, no ulcers.
Sir.
Biopsy of any trial you know of which is recently published, which talked about non-operative measures after giving new emergency CT artery in a cases of response.
Sir, yes, sir. What's the name of the trial? Yesterday's a trial. Similar to hypergamma approach.
Okay. We can proceed further, sir. Dr. Partha, sir. Yes, sir.
What lymphadenectomy will you do if you're doing a total lymphadenectomy in this patient?
Sir,
would you do a transhiatal approach or a transthoracic approach?
Sir, transthoracic approach.
Why?
Sir, because transhiatal, because it is the mid-esophagus near the carina, so it will be difficult to see, and there's a high chance that can cause injury. If it is lower thoracic esophagus or near the G junction, then it is better to go for transhiatal approach.
Any other reason?
Sir, sir,
there was some issue with
lymph node.
Close proximity to vascular structure.
Yes, sir. So there is a chance of injury. Yes, sir, with transhiatal approach.
Okay. What lymphadenectomy you want to do?
Sir, sir,
lymphadenectomy is esophageectomy.
Sir, standard 2-field lymphadenectomy, extended 2-field lymphadenectomy, and 3-field lymphadenectomy. As this patient is not having any lymph node, standard 2-field lymphadenectomy.
What standard two-field lymphadenectomy? What areas? Dr. Partha is asking what all.
Subcarinal lymph nodes, all the subcarinal mesenteric lymph nodes, and the abdominal lymph node till the station 9.
What about recurrent laryngeal? Are they a part of standard two-field lymphadenectomy?
So recurrent laryngeal lymph nodes are part of extended two-field lymphadenectomy.
This patient has lymph nodes, no? She had a PET avid node which became non-avid after therapy.
So that was gastrohepatic, sir, abdominal lymph nodes. Chest.
What reconstruction you want to do?
Sir, with the gastric conduit, I would like to use the gastric conduit and esophagogastrostomy in the neck. Yes. With feeding diagnostic.
If you have a intraoperative injury to the left bronchus, how will you manage?
Sir, in the intraoperative, sorry, sir.
Yeah, go ahead. Yeah.
Sir, if there is an intraoperative left bronchus injury, then I would ask the anesthetist to extend the tracheal tube to the left bronchus, and then I would like, and I'm seeing that I would like to take the sutures in the left bronchus.
What endotracheal tube do you use during these resections?
Sir, double lumen.
And the main tube goes into the which bronchus?
Sorry, sir.
You've seen a double lumen tube?
Yes, sir.
How many pins are there for? How can you insert the tube into the left bronchus? You basically exclude the left lung.
Yes, sir.
Okay. And then you repair it.
Okay, sir.
Sir.
So, like you were talking about the lymphadenectomy, standard lymphadenectomy is infracarinal. Then we have an extra one when we remove the lymph along the right recurrent laryngeal, and another one is total two-field. That involves the left side also.
Bilateral, yes.
Lateral recurrent laryngeal nerve. So, what is the watershed area in esophagus?
Sorry, sir.
What is the watershed area? At what level the lymphatics goes up and lymphatics goes down?
So carina is the watershed.
Carina. So it is usually that if the tumor is in the lower thorax, it will go in the towards the cisterna chyli. But because this tumor is starting in the mid thoracic, so the lymphatics can go in the upward direction also. And when the lymph get blocked, they don't follow that routine course. So it is, if the lymph nodes are present, it is better to do lymphadenectomy in total two-field. And because the abdominal lymph node are present, so it is always advisable to do a good lymph node dissection in the abdomen. Okay. And any other thing, Dr. Jeswanth, Dr. Partha, then we can, I think it's 9-10. Comment from other faculty members.
Yeah, I think Dr. Shastri, Dr. Supe, Dr. Deepak, Dr. TD, can you come in?
Good morning, sir. Hello.
Morning,
Hello,
TD.
Pradeep.
Good morning, TD. Go ahead.
No, I have a few comments regarding the answers being given by the candidate. The first of all, like one advice that all of them should go to the radiology department and try to learn how to see the CT scan and what are the terminology used. And more so when Dr. Vaibhav asked about the how you divide esophagus in multiple levels, cervical, upper thoracic, middle thoracic, and lower thoracic. And then the boy was not able to answer, which is not correct. So we must know the anatomical landmark. And one more important thing while listening, we know that optimal use of limited resource, like when Dr. Jeswanth said, if this patient has a multiple mets in the liver and lung, then still I will do a PET scan, which is probably not correct in terms of management. We are not going to achieve anything more by doing PET scan, because already liver metastasis, esophageal metastasis, to my mind, is a very limited survival left, and palliative chemotherapy is the only answer. So what more we are going to see by seeing the decreasing level of the SUV max? So this is very important. And then at the end, there is a tumor at the carina level, close to the inferior pulmonary vein and left bronchus. And then he says, I will do Ivor Lewis, which is limited. You are leaving about 3 to 5 centimeter of the esophagus, and close to the margin. Ivor Lewis is not a appropriate answer. So these are the certain points which are very important. The rest of the things have been covered by the moderators. Thank you.
Dr. Shastri.
I think he has done fairly well, apart from a few glitches Yadav has pointed out. What I want the residents to remember is in a rapidly evolving situation of CI esophagus, it's good to keep your eyes and ears open and keep all the options and multidisciplinary management. It's not your decision alone that is important. And the radiological assessment and the role of the next generation sequencing, which is going to be definitely in the immediate future is going to be very important because of the targeted agents coming into the treatment arena. And the last is the surgery after definitive chemoradiation in a completely resolved or a clinical total response. That is still an ongoing debate. And you have to really discuss with the patients and patient settlements, because the final word is still not said about this. So you'll have to keep the options open and not rely on just 1 or 2 reports that 70% would recur. That is not a right approach. I think these are a few comments I want to make, but I think I should congratulate him for keeping his cool and discussing all the options for his standard.
Dr. Deepak.
Yeah, I think overall is done well, but 1 or 2 things I just wanted to point out. One is like PET CT and CT. Usually we do a PET CT, but we tell the persons that you have to do the CT more accurately, because the CT sometimes done with the PET is not as good as we do a contrast and a CT. So I think that is one thing which needs to be stressed if you're doing a PET CT. Then regarding endoscopic ultrasound, I don't think that lymph node biopsy or FNAC is going to change the management in any form. I think it should have been, I don't think there is any point in unnecessarily going into that and getting a US guided lymph node biopsy. Overall, he's done well and his approach has been good.
Dr. Supe, sir. I think Dr. Supe is not there. Okay. I think you have done well, Gautam, and as all the panelists have this thing, but I think you should be more concentrate on anatomy classification, that there's some confusion there, right? You're not,
Yes.
didn't seem to be very confident. I think overall you're done well. So can we wind up? There are questions, Q&A. The moderators can take up, and the Q&A. Some people have posted some questions there. Vaibhav or Jeswanth?
I think the first question is instead of Ivor Lewis with surgery, so McEwan's esophagectomy is the answer which you should have given in this case.
Yes.
Lower thoracic esophagus, so you should do a minimally invasive transthoracic esophagectomy and then gastric pull-up and then cervical esophageal anastomosis. So in US malignant lymph node, what is the criteria called, sir?
It's called RICE. No?
Sir, what
RICE.
Partha asked a question that what is the criteria called for malignant lymph node?
It's called RICE criteria. RICE.
Yeah, so this is the answer. Then the other question was, should we directly say ultrasound when we have not ascites or no lump? So it is always better to say ultrasound to rule out any liver SOL or any ascites. So this is extended investigations. The last is, should we say directly PET CT or should we say CECT followed by PET? So you should not say PET or say CECT. It is always better to say PET CT, and then you should be able to defend that why I am doing CT is because it will give you a better clinical T and end staging, and PET is required to rule out any metastatic disease. And the next thing is, because I am going to do I am going to give neoadjuvant therapy and the better response assessment, because whatever the SUV, because there are criteria that how much percentage SUV is decreasing will have a implication on the survival also. So that's why it is nowadays, if it is available in-house, and then PET CT is the it's okay to go with. Anything else? And then the trial name is SANO trial, which you should read. That is that SANO is surgery as needed for esophageal cancer, SANO. So this is talking about the active surveillance, and you will find many articles on this topic where after giving in squamous cell carcinoma, particularly after giving neoadjuvant CTRT, people are going for an active surveillance and looking for the results. Anything concluding statement from Dr. Parthasarathy sir and Dr. Jeswanth sir?
No.
No.
I
Pradeep
think,
sir?
yeah,
Yes, sir.
thank you, Vaibhav, for, I think, the summarizing the question, answers to the questions. I think we'll thank all the panelists, and special thanks to Vaibhav, Jeswanth, Parthasarathy. Thank you, one and all.
Thank you, sir.
Thank you,
Thank
sir.
you.